8 o'clock, and I don't want to let things drag out too long. Welcome to the uh, 18th Elliott Podol Lectureship in Adolescent Medicine. If you've read the scroll, you may be familiar, have read about the fact that Dr. Podol had been a general pediatrician here in Louisville who, although he was from Savannah, Georgia, made his career here after medical school and training. About 20 years into his career as a general pediatrician, he realized that there were things going on with adolescent patients that he didn't feel well equipped to handle, but wanted to learn how to handle. So he left his practice, went up to Boston Children's, and spent a year of studying adolescent medicine and adolescent psychiatry, returned to Louisville. And back when I was a medical student, and way before it was a requirement, Dr. Podol came and lectured medical students and residents about adolescent medicine and the health needs and the developmental process of adolescence. He continued to practice here until about 78 when he was hired to join the faculty at University of Miami School of Medicine, and went down there, and unfortunately, after developing lymphoma, passed away. His widow, his son Ron, who was a classmate of mine, and Steve Wrights, and his daughter Rosalie, an attorney, gave a gift to the School of Medicine and the Department of Pediatrics to fund this lectureship, and we've been fortunate in having experts in adolescent medicine come and enlighten us as to what we need to do, what we could do to improve the health care given to adolescents. And this year's no different than previous years. We're fortunate in having Dr. Stephen Matson, who's the Director of Adolescent Medicine at Nationwide Children's, and an 8-physician division of adolescent medicine that provides care to teenagers there. He's also the director of the medical treatment for addiction clinic at Nationwide Children's. He's also the medical director for the detention center for Franklin County, the juvenile detention center for the Columbus, Ohio area. His adolescent services take care of kids with eating disorders, reproductive health needs, and all the typical needs that teenagers have. But his special focus and his national expertise is in taking care of kids with addictive disorders, and that's what he'll be talking to us today. He was the first recipient of the Founders of Adolescent Medicine Award from the American Academy of Pediatrics, and after his talk, you'll understand why he was given these prizes. Thank you.
Oh, thank you. Yeah, I got that Founders Award before anyone figured out it was an important award, so everybody after that is famous. So while we're fidgeting, this seems loud, but yeah, I got into this addiction stuff kind of later in my career, but I found it to be one of the most rewarding things I've done in my whole career. It's especially with the heroin opiate addiction, it's just such a nasty disease, and people look awful, and their lives just are in the toilet. And it's extremely dangerous. They say I lost one sickle cell patient to a chest crisis back about 30 years ago, and now I've lost like 6 of our patients due to overdoses. So extremely dangerous disease. And, I really think the American Academy has finally stepped forward and say we need to start doing things about it. And so I'll just talk to you a little bit about addiction and what we're doing in Columbus. I kind of fly through slides, so if anything piques your interest, feel free to shout out. So I grew up in Minnesota. And we get started early. I did play hockey terribly, but I think if those of you who've done your adolescent rotation, you always kind of what you have to do to go from being a kid to an adult. You got to break away from your parents. Got to kind of come to grips with yourself as a sexual being. Kind of figure out what you want to do in your life and develop a self-identity. This is painful. So I separated from my parents. They were pretty glad at the time. These, believe it or not, were cool at the time, yeah. Yeah, got through puberty. That's as good as it gets right there, yeah. uh, I had my first crush. People still know who that is, right? Joan Jett, right? She stood me up here. I was going to come down and see her at the Yum Center, and somebody got a sore throat, so catch you later. Came to grips with myself as a sexual being. Got some good training. Uh, Again, right time. They had to take us Minnesota people back then. I wouldn't have a snowball's chance in hell of getting in there now. I was their token Finlander, I think. But finally got a stable self-identity. So anyway, this is what we're going to try to cover. Just a little better idea of what addiction really is. Just quickly go through what teens are kind of doing. Look at the opioid problem. Then kind of look at how we take care of the kids that come into our program. Talk about medication-assisted treatment. And then how we're doing. So I think we were talking last night, the stigma of addiction is still pretty bad. You know, I think addiction is kind of 20 years, I always say, beyond mental health. I think we've all kind of gotten comfortable with the fact that some people need Prozac and some people need it their whole life, and it's a real disease. But, you know, I think there's still a lot of people that believe that, you know, they just got to stop doing it. But I think now we know it's a real disease, and I think it's very important to remember that I've never met a heroin addict that wants to be a heroin addict. So it's really something out of their control. And you know, this wasn't that long ago figuring it out, but you know, dopamine is basically our pleasure neurohormone. And these scientists went back and looked just when rats eat or they have sex, their dopamine goes up. Then a few people went and looked at all of the drugs, and basically dopamine high every time you try to use it. So it's chasing that dopamine high. If you're interested at all, this just came out from the Surgeon General. It's a really excellent monograph, really kind of laying out what we need to do in this country to battle addiction. But basically the three big areas, your prefrontal cortex, basal ganglia, and the extended amygdala. And that basal ganglia is where all the dopamine is, and that's where all the pleasure comes from. The formation of habits also happens. The amygdala is involved with kind of post-use stress and the irritability and withdrawal. And the prefrontal cortex, of course, is where everyone makes decisions. And how many adolescents have a functioning prefrontal cortex? Not very many, right? And as we've seen in substance abuse, men are much later. I think all the women know that. But so, you know, a lot of men probably don't get mature in that decision-making area until they're 23, 25, whereas women are much earlier. They grow up faster. So the basic stages, obviously the use, you start to get withdrawal, and then the preoccupation or the craving. And it's really the major problem with opioid addiction is the craving is so intense that it's just hard to even pay attention to a class or do anything. So it's so important to extinguish that craving. And we know now that in the prefrontal area, just thinking about using gives you a dopamine burst. So people just get super excited already trying to think about it, and drives them to keep using. So basically this cycle of going around and around. And really, it's pretty much out of people's control once that gets going. And just a reminder that, you know, the dopamine, this is using cocaine, which works directly on dopamine. Opioids bind at the mu receptor and work on GABA to release the brake that GABA has, and that leaves the dopamine out. But if you keep using, I'm going to use the word downregulate. I'm not sure that's the right word, but you get less dopamine receptors. So obviously, you need more and more drug to get a positive response, and they can actually show that on scans. Much more dopamine receptors and less. And this just shows that it's basically the same with every type of addiction, that good dopamine receptors, messed up dopamine receptors. And this has a lot to do with why it's hard to treat people, because it can take a year or more for that to recuperate. So the definition, basically, it's a chronic disease. Like we said, reward, motivation, memory. Leads to pathological pursuit of this. And I think this is so important. You know, a lot of addiction people use the analogy of diabetes, that we get a lot of diabetics that go off their thing, they come in, they need help, then they go back on. And it's very similar with addiction. When we start someone, we know they're going to relapse because it's just too hard to not. And it's just a matter of decreasing those relapses and getting back on the horse and going. And then, you know, I think the reason we're so important is because virtually all addictions start in our age group. So the best treatment for all this mess up would be to stop teenagers from becoming addicted to drugs. I'll say marijuana because I'm not a big fan of legalization of marijuana, and we do know that you know, marijuana is a gateway drug for our kids. Obviously, lots of people use weed and go on and become lawyers, maybe not doctors, but and they do fine. But you know, it's that group that's got a problem with addiction where they go on and keep using. So obviously, prevention would be great. And I think, you know, a good thing, just while we're talking about it as a pediatrician, you know, when you're talking to your kids about weed, weed really is the first time kids learn to get high. I mean, alcohol and that and cigarettes kind of treat some basic stuff, but weed gets you high, and that's the first time they learn how to do that. So really trying to get kids to understand, one, try to wait as long as you can before you do it. Because we know that if you start using weed when you're 12, 14, you're looking at a long time of problem usually, because the brain is just starting to form. You form your brain needing marijuana in there. And those kids tend to do very poorly, much higher chance of going on to have a drug abuse problem. So if you can wait till you're 18, 19, much like just about every other risk-taking behavior in the world, so if you wait till you're 18 or 19 to have sex, you're probably going to be better at birth control, not get STIs. So waiting, and then if you do it, just infrequently. So not daily, but maybe. And traditionally, for separating teenagers, risk-take, just a little experimentation. Obviously, a kid that goes to a party every once in a while, smokes a little weed, still an A student, probably not a problem. But a kid that's doing it every day definitely has a problem. So we kind of covered that. So just quickly, what kids are doing. So there, you know, there's a few surveys that kind of constantly look at what drugs kids are using. This is from Monitoring the Future study out of Michigan, and they basically do a large survey of all kids that are in school and what they're using, and basically, no surprise, alcohol. And just remember, with alcohol, most adolescents, when they drink alcohol, drink to get drunk. So most are doing binging, which makes that pretty dangerous. Cigarettes, weed, opiates. I just do this in because I think it's kind of interesting that we've noticed it, like in Ohio, and actually I think here in Kentucky, which I'll show, that actually more kids are smoking weed than cigarettes these days. But interesting that if you look from 11 to 15, that cigarette smoking has dropped, but e-cigarettes have basically taken over, so kids are vaping. And you see it all the time, and you know, there's a little thing in you that says maybe that's safer because it's just nicotine, but nicotine is pretty addictive. Hookahs, I'm sure we've all smoked a hookah, right? So this looks at Kentucky, and the same. I think we reversed in 11, but here you guys in 2013, more people smoking weed than cigarettes. And then they throw in this, and this is from the YRBS, the Youth Risk Behavior Survey, which is done like every other year. And basically, again, it's school, 9th grade to 12th grade, and asking a series of questions about use. So that e-cigarette stuff, and I think in JAMA yesterday came out a big statement on e-cigarettes that we probably, as usual, are a little late in attacking that, but And we see our patients vaping weed all the time, and you can't tell it is, so they all got THC in school. So finally getting to opioids. So this is a big map looking at back in about, 16 years ago. Blue is purple, not so much, red, and you can see this little nidus over here that kind of is you guys and kind of is kind of is West Virginia. And then as time goes by, you can see it's really blossomed into our area. And a fair amount out in New Mexico and that too. And this just a little higher resolution. I'm not quite sure where Louisville would be. Could that be it? Right there? Over here? But anyway, right now, pretty bad shape. And that's 2014. So you can see it's, and you know, a lot of this people feel came out of hard-working people that were working in the mines and that got injured. And, you know, we were trained as doctors to relieve pain, so it seemed like the right thing to do to give people a lot of opioids, but it really ended up causing a big problem. This just looks at pure number of deaths. So we win that award. We have more overdose deaths in Ohio than anywhere else in the country. But, you know, not too far behind here. This is sheer number, but when you go by population, you can see Kentucky, West Virginia, Ohio are way up there for how many deaths are occurring per person in that area. This just shows the actual numbers. So West Virginia, pretty bad. Ohio, Kentucky. So we'll just look at Kentucky a little bit more. This came out of your youth risk behavior survey. 17% of kids have smoked weed in the last month, which is sort of use. 3.7% have used heroin, 12.7% have used prescription drug when they weren't supposed to, 7% have used inhalants. We don't really see much inhalant stuff because usually you just die if you use inhalants. So lots of times kids are bagging, they'll put a bag over their head, put the gasoline in there, and pass out, and lots of times they'll just die. You see kids with redness on their face, they come in sort of obtunded, you worry about that, but important thing to warn people about. So I called in, hopefully I got the county right. But I called in, they gave me this number. So if you got that number of high school students, that means 1,300 have used heroin in this county, which is pretty amazing. 4,500 have taken prescription drugs, and 6,000 are smoking weed at least monthly. So this just looks actually over time, and you guys are sort of this red here, and just kind of a gradual, I've lost my pointer, but a gradual increase for Kentucky and West Virginia, and you can see Ohio taken off. Anyone know why Ohio is so bad for overdose? Little League. Yeah. Luckily, I'm a Viking fan, but that went bad too. So, it's heroin, right? And it's okay. No big deal. Oh, wait, I need to go forward, though. You were fine. So you'll see here, if you look at where most of the deaths are coming from in Kentucky, it's actually the opioids, oxycodone, hydrocodone, and the fentanyl, which probably is intravenous. But so if you look in Ohio, almost 60% of people overdose deaths are from heroin, whereas a lot lower in your states. But I'm pretty sure it's coming. And I'm pretty sure it's here already. But, and the basic reason is money, because a couple of Percocets probably run $30, $40 a piece on the street, and a tenth of a gram, which is the usual dose of heroin, is about $10. So it ends up being sort of a monetary decision. But it's also actually a business. And the story, which you've probably heard, but the group down in Mexico, Jalisco, started a plan to bring heroin into the United States. They decided they weren't going to go into big cities where there's police and already other types of drugs. So they decided they were going to go into rural America where there aren't many cops and where there's hardworking people that if it had injuries. So actually, most of the heroin for this whole side of the country comes into the West Virginia-Ohio border and then gets distributed from there. And they actually, you can call, they'll deliver it, they'll call you the next day to ask you how good it was and ask if you want some more. So it's very easy to get it. And that's another reason. It's not just money. It's just that you can, it's like your Uber Eats. You can just call them up and get your heroin delivered to your door. And very similar to us in Ohio. Oh, amazing. But if you look at accidental deaths in Kentucky, 60% of all those now are due to drugs and only 22% to car accidents. And I think we surpassed car accidents in like 2009 or something in Ohio. So that seems pretty crazy, right? More people are dying of heroin overdose than car accidents. So fentanyl has arrived to Kentucky. So fentanyl, you can take it orally, but probably a lot of that is intravenous. And so in Kentucky, you can see a big factor, 420 of the overdoses in 2015. And fentanyl caused 34% of all the overdose deaths. So, you know, we always kind of judge everything by morphine. So any idea how much stronger heroin is than morphine? It's about 3 times, so a little bit stronger. Fentanyl's 80 times more. So somebody who's messing around with a little heroin and takes the same dose of fentanyl probably isn't going to wake up. In Ohio, we've been running into carfentanil, which is 10,000 times stronger. I don't know, have there been cases of carfentanil in Kentucky yet? So any idea what you use carfentanil for? Use it to put elephants to sleep. So extremely deadly. And, you know, about all the Narcan you can give isn't going to reverse that in a lot of people. So we get little shipments come in and we'll lose like 20 people in Columbus because they're using drugs like that. This is one thing that gets everybody excited. The babies are getting harmed. It's like, well, if we just treat the people, we won't have the babies. But we definitely have the abstinence problem, neonatal abstinence syndrome, big in this area, dramatically increased here, 2000, less than 30, 13,950. So I think yes. Not as big as we have, but it's getting there. So just a few quick things. I mean, these are probably obvious. It's just like a lot of other medical problems. The parents bring in a kid, and it's like, we know right away there's something going on, but the parents are still kind of wondering if it's okay that their good silverware is missing and that their kid stopped playing football and is hanging around with a bunch of seedy-looking people. But secretive lying is such a big part of addiction. So when you start to get that feeling that kids are lying, that's a really important sign. And that privacy thing. Privacy and lying. Addiction is an individual problem. It's an alone problem. It's something they don't share with anyone. And really, treatment is stopping that and getting them to be around people that are in therapy. So yeah, I'm sure you get in the hospital, somebody calls and says, oh, this kid is smoking weed every day. What are we going to do? And actually, it's not that hard because basically everybody just needs a full substance abuse assessment. And until you get that, you don't really know what to do. And really, that assessment drives how much care they need. So a kid that's maybe just doing a little alcohol and weed, and they might be okay seeing a therapist once a week for a while. Once you get somebody that's really got an opioid use disorder, in a perfect world, residential placement would be the answer. So the biggest problem with most of our patients is the environment they're in and the people they're around. So unless you can pluck them out of there and not be around them, it makes it very difficult. And we hear it over and over again. I was doing well, did 2 months without using, and then an old buddy of mine showed up and we used. So, and traditionally we say at least 90 days in a residential program to get people away from that routine. What's the problem with trying to get people residential treatment? Yeah, almost no insurance company will pay for it. Even good insurance won't pay for it very well. And the few residential programs tend to be programs that are connected with law enforcement, and so you kind of have to be in the system, which sometimes is a pretty good solution for some problems. Is, you know, they're doing enough, call the police and get something going so we can finally get your kid into some treatment. So we got this, how's it happen? I'm still a believer, you know, the opioid problem, and just really trying to help parents understand that, you know, if we give your kid a bunch of Percocet for the broken leg or something, you don't give it to him to take it as he needs it. So that's still a parental monitoring, which I still feel with the ADD meds as well, because those are very often diverted. The parents really should be holding those meds, giving it to kids. And kids are so smart these days. They go over to a friend's house and they're rifling through everybody's medicine cabinet looking for opioids. So we really got to work to get those off the street. Yeah, we're doing good. So I would say, you know, we obviously see the far spectrum, but it almost universally the story is they start smoking around 10, drinking, doing some weed maybe around 12, 13, learn that high, go to a party, try some pills. Usually after taking them orally, we're crushing and snorting the pills to get a bigger high. Money and service takes over and they become addicted to heroin. So what can we do? This is not an uncommon story for us. Our average age is still like 18 and a half, but so that obviously means we got a fair number. I think the youngest addicted to heroin was 14 we've had in our program. And you just hear these awful stories where kids are living in a home where everybody's shooting up, and sometimes it's the kid's job to inject everyone because they're the only sane one around. So terrible situations. So you can send somebody off to 6 months of wilderness rehab for $85,000. Almost universally doesn't work. And it's not unusual that kids come back from something like that and use their old dose of heroin and overdose and die. So we need access to some sort of affordable care. So obviously without drugs, it's residential, intensive outpatient, 12-step, individual, therapeutic community, so a place where you go live and everybody's going to 12-step meetings. So what do we have pharmacologically? Replacement therapy, which is medicated-assisted treatment. To me, methadone is a drug for people that fail other methods. It still works good. It keeps people from injecting. It's a good harm reduction. Naloxone is what we'll talk more about. Withdrawal-based treatment where you go in, they might give you some buprenorphine to make you feel better and then give you a wean off in 2 weeks. Almost universally fails. And then the antagonism, naltrexone, we'll talk a little bit about that. So why do I think you need to choose the medicated-assisted treatment? If you don't do it, the relapse rate is incredibly high. And I think when they do these lifelong studies, something like 50, 60% of the people die ultimately if they don't get some treatment. The cue response that we talked about, that craving, our kids will say, I was in the pharmacy and I saw some insulin syringes and I just had to go use that. Just those cues of things that they think of that makes them go. We still get some of our patients, they'll go to the dentist and they'll send them home with Percocets. And even our friends in the OBGYN haven't always quite figured this out either. They'll deliver one of our moms that's been on buprenorphine and then they'll send them home on Percocets. Yeah, not good. I think ultimately, though, the one important thing to know is that even though we do this replacement therapy, almost nobody gets better if they don't get some of the behavioral treatment. So our big goals when we're using the medication is to completely extinguish withdrawal and craving. So when somebody comes in, they say, well, I'm still kind of craving, but it's much better. It's like, no, we're giving you more, because any craving at all pretty much means it's not going to work out. And then, some of the harm reduction, obviously, which we'll talk about a little bit. And then this sort of idea of office-based treatment. Adolescent medicine has always had that, has used that as a tool, instead of walking in Planned Parenthood door where obviously I'm having sex. You can walk into a physician's office here and really not know why you're going there. So our heroin-addicted patients are sitting right out there with people getting physicals. You maybe can tell who they are, but it allows for parents to still be involved. And this is really important. If this medication, at least initially, is amazing, because we'll see someone who can barely talk that comes in suffering. We get them on the buprenorphine, and the parents are like, thank you for giving my child back to me. And because it makes people normal incredibly fast. There's a lot of work to be done after that, but kids really can get back into school very quickly because they're not constantly thinking about using. So buprenorphine is what we're talking about. Remember, when we use opioids generally, dopamine is released. Get lots of warm and fuzzies here, all the pluses. As those opioids come off, we start to get that negative feeling. As more come off, more and more negative withdrawal craving. And what the buprenorphine is a partial agonist, so it doesn't have the full effect. It's still a strong pain med, but you cannot overdose on buprenorphine because it has a ceiling effect. So no matter how much you take, usually you won't stop breathing. I've never heard of anyone dying. Now you get a little kid who takes a bottle of buprenorphine, that might be a problem. But I think the newer forms have made that less likely. So these little green snowmen are the buprenorphine. So when they come on, you can see they get some pluses, not quite as high. And then once they get all the receptors bound, it's sort of showing the little patooey, very strong affinity to the receptor, and you can't push it off. So if they're taking their medicine, it should be hard for them to overdose if they make a mistake. Most of the medication combines buprenorphine with naloxone. Why do you think we do that? And more importantly, if you dissolved that and injected it, what would happen? You'd be pretty sick. So that they throw the naloxone in there so that it's less hard for you to actually use it as a drug. And so there are forms of straight buprenorphine. We never use it because it's just so sought after. And a lot of people still feel like pregnant women need only the buprenorphine, but really most OBs that have worked with this now are using the combined form, and they're doing fine. Naloxone is a little high in I think it's a C or something, but a lot of things are C, so we use the combined. So yeah, here, what happens if I take two, which a lot of our patients wonder. So this was the original form, these tablets. So you can imagine you have a bottle of 60 of these tablets. It's very easy to give one to your friend, and you take one, sell 5 of them, and stretch it out. So the next form that came is the film, which is mostly what we use. Insurance companies will make you use different forms. The other common form is called Zubsolv, which is also a combined form. All these are sublingual. Bunavail, I'm not sure how to say it, is supposed to go on the cheek, so maybe people that like to chew tobacco like those. Most of our patients haven't liked it. But generics are available, but the problem is a lot of the generics are pure buprenorphine, which is really dangerous. So here's beautiful Nationwide Children's Hospital, just done, wonderful place. But this is where we see our patients. And Ken, I probably could get killed for using that old logo too. Now we have pretty butterflies. And then somebody figured out butterflies are like the thing for when people are deathly ill and going away, but they've tried to stick with it. So I really think that the best answer and something we can do is this integrated care. There's a lot of people I'm sure you've seen making a lot of money right now doing Suboxone mills where basically 6 people come into a room, a doctor says, how you doing? Then they slap their cash down, get their buprenorphine and leave. And there's a lot of money to be made with that. There's some nice cars people are doing. And I was on the board for taking the board exam for addiction medicine. And we had like radiologists trying to get board certified in this because they can make more money doing this than doing radiology. So the right way to do it is to integrate them into the normal care. And because so much of this is all connected, the medical, the mental health, the substance use, we can get people in super fast too. So if you try to get into a treatment program, often it's a month or 6 weeks or more before you can get in. And when people are ready to try to make a difference in their life, it's really important to get things going. So how do we do it? So most people come to us by word of mouth, actually, because word spreads quickly when things are available. It's actually in our state, it's relatively difficult to be on Medicaid and to get treatment just with your insurance, which is silly because they pay for the medical visit, they pay for the medication, but still a lot of people on Medicaid end up going to these pill mill sort of things. But when they come to us, usually it's very obvious what's going on, and they look like death warmed over. Do a physical exam, obviously looking for track marks, murmurs, abscesses. A lot of our patients are picking just part of the disease and will come in with scabs all over their faces. Obviously hepatomegaly, signs of withdrawal. Most people have used like within 12 to 24 hours when we see them, so they're not super sick. As part of the whole comprehensive, obviously, screening for infections, we do a full hepatitis panel. We just found due to the addiction, they lose their sort of immune compromised, and a lot of them have lost their hepatitis B and their Hep A if they've had it immunity. So we recheck that and re-immunize everyone because especially if they have hepatitis C, about 40% of our patients when they present already have active hepatitis C. We have not seen the HIV outbreak like happened in Indiana. Anyone know why that spread so fast in Indiana? It's a little tricky, but actually most of those people were injecting tablets, so they were solubilizing. And to do that, you have to push the stuff through a cotton ball to filter it. And people were reusing that cotton ball over and over. So the HIV would get in that cotton thing, and then they just keep injecting everybody else. So a little higher, actually injecting pharmaceutical tablets is actually more dangerous than taking heroin, which seems crazy. But obviously, very important to have a point-of-care urine test. For some reason, this thing, it's kind of back-asswards. When you get the line, they're good. So yeah, it wouldn't be good for a pregnancy test because you'd scare a lot of people. But and then it also gives you a little adulteration because our kids will mess around with things. So it does give you a temperature so you have some idea. All of our urines are witnessed, actually. But, you know, I think if you get people to empty all their pockets and take their coats off, we can still be well. Our kids still will put a little film of buprenorphine under a fingernail and drop it into the urine when they pee. it's just crazy. And these are just a few other adulterations. There are ways to get around that, but I won't talk about. But we have ways to figure out when people are doing those things. So we go over the test. The big thing for us is we want to make sure. I guess it's not. I'm sorry. Every positive there is presumptive. It's not a perfect test, so everything needs to be sent out. I assume you have some sort of prescription monitoring program in Kentucky. So we're required every time we see the patient to look that up and document it in the chart. And obviously now, too, any minor that we see, we have to get parental consent. We have a parental consent for opioid prescribing. Is anyone certified actually here? Buprenorphine? It's actually crazy. It's incredibly easy to do. It's like 4 hours on a computer. If you go to the American Academy of Addiction Psychiatry, you can do it online. And then you get your X number from the DEA. And so it's really not very hard to get. Obviously, they want to try to get people to use it. So basically, when we see them, and if you take that course, they talk about giving them a little bit, watching them, giving a little bit, watching them. But we've been home detoxing people since '09, and it goes fine. So basically, almost everybody we see now is injecting heroin like 8 or 10 times a day. So we go to our full dose at the beginning, which is 16 milligrams, which are 2 of the 8 films. And even though, usually it takes longer for it to clear, we found that if there's a good 12, 24 hours, they can usually start the medication. The urine drug screen is important to be looking for methadone, because if methadone's in there, it lasts a long time. We've got to wait till the methadone clears before we start the induction. As we said, 16. Sometimes we'll do this. So these are all the old traditional treatments for opioid detox, a little something for nausea. Clonidine really works on the withdrawal symptoms. A lot of withdrawal symptoms are driven by norepinephrine and the locus coeruleus. So that's why clonidine works. It blocks that effect. Most of our patients don't need any of that stuff. These are the hard things for the parents to understand, but we always say there basically has to be a lockdown, that you got to know exactly where they are all the time, where they're going. This seems obvious, but it seems really hard for people to take kids' phones away. But everything they know about how to get drugs and everything is on that phone, so that they need to take it away. And if we're seeing a 19-year-old, we say the same thing. You got to get rid of your cell phone, because obviously we try to have a trusted person manage the meds, because it's just so easy to take an extra one. So trying to get somebody to do it and keep it safe, because people in the neighborhood find out somebody's on this med and they disappear really fast. Why do you think people steal Suboxone from people? Sell it, number one, right, to make some money. But it turns out people talk like they're abusing buprenorphine, but they're not. No one's abusing it. They're using it to not withdraw. So when they can't find their drug of choice, they have something that keeps them from getting sick. So a few things, we try to get them to bring their empty wrappers back so that we know each film is individually packaged. They actually have a unique number on that. Pharmacies haven't really picked up on it yet, but it'd be nice if they would. Proper technique for the film, or the Zubsolv, is usually tell them not to smoke or drink coffee. That kind of vasoconstricts, so you want everything open wide to absorb the medicine. Rinse out with warm water to get things dilated. Put it under the tongue. Put the tongue down. Don't move for 10 minutes. After that, you can swish and spit it out. So when we get, and even if we've gone through all that, they come back and I put it on top of my tongue and I swallow it. And it's like, yeah, well, that's not going to work. So, or I get so much saliva, I swallow it all. And so really, if they just put it down 10 minutes, they're good. And that's the beauty of the new forms. Is the old tablets took like 25 minutes to dissolve under the tongue, so this is much faster. Usually we see them back weekly. Once After they kind of are getting with the program, we start stretching it out 2 or 3 months. Once they're consistent, and once somebody's doing great, we're usually seeing them monthly. Like I said, lots of times we're managing the other issues. I think so the mental health, a lot of people look depressed and anxious when they come in just because of the drug use. So we try to get them clean for a while before we really assess the mental health stuff. But I'd say 60-70% of our patients need something for social phobia, anxiety, and it really helps them succeed. This is a little tricky area, but I think it's part of the reason so many of our guys fail is that I think we have a lot of our patients have attention deficit. But it's kind of scary giving a stimulant to a heroin addict at the beginning. But if somebody's doing well, by 5 to 6 months, we'll usually add it on and just make sure we're using the ones that are least likely to be abused. These are just the follow-up stuff. So a lot of discussion about how long somebody needs to be on the medication. Our feeling is they need to be on it as long as it takes to stop from using. So I would say a standard patient for us is somebody does pretty well for a year, maybe, on the full dose. They're feeling good. They're ready to start to taper. We usually go very slowly by 2 milligrams, maybe every other month, so that by maybe 3 years, they're down to a very low dose. And at that point, about half of our patients go off and half stay on something like 2 milligrams. And we have people that are 6-7 years out on 2 milligrams that are doing great, graduated nursing school, working, lucky enough to not have a felony charge, and so they're doing great. And I already sort of talked about that, and we talked about why especially that full year, I think, of full dose is needed to allow the brain to heal. And just, if we don't ever make anyone wean, sometimes we may have to give them a little push because they're so happy being where they are, but they start to get in trouble, we'll definitely go back up. So how are we doing? So this was our first look. It's a hard disease to treat, right? And this was our look at 2009 to 12, and 25% of our patients didn't come back for a second visit. That's pretty depressing. 45% retained at 60 days and only 9% at a year. So yeah, kind of sad, right? The thing that I was telling myself at that time was, at least they get a taste of not using, and they get a feel of what it's like. And maybe, and it turned out that when people come back, they're just as likely to succeed as anyone else. So sometimes people just need to try it and come back. But we did, in the spirit of quality, has quality hit the hospital yet? Yeah, I have to say, when I first met quality, it was like, lame-o. But, it turns out it actually works. And the thing it does is it allows you to make interventions and actually see how quickly, you can see quickly whether it's working or not. So we kind of design, and I'm sure you've seen key diagrams, but so we instituted that. And what we found is, obviously, I think our patients really respond to being welcome because they're so used to feeling like a piece of crap. So we really try to make them feel positive. Thank you for coming. I think we can really help you out. I'm glad we've got you at this time. I think when we originally started, we were a little afraid of the DEA because they come calling to almost everybody that gets an X number. And they want to see your records. They want to see how you're prescribing. And we were a little afraid of them at the time. We've been visited now 3 or 4 times, and they're obviously perfectly fine with us because we're pretty comprehensive. I think we're one of the safer programs. So we really lightened up. When we first came in the old days, it was like, you got to go to 12-step meetings. You got to get into treatment before we see you back. And I think we just overwhelmed and scared a lot of people. So now when we see them, basically the message is take your medicine, don't use, and come back in a week. And I think that has helped a lot. We try to emphasize, you're going to screw up. I can guarantee you're going to screw up. So we're not going to kick you out for screwing up, especially if you just tell us you screwed up, because it's that getting over that line and everything that really makes a difference. Obviously, all of us were trained in MI, which I think is important. We use contingency management, so if somebody is chronically misbehaving, we might drop the dose a little and then come back. Our incentive programs really help, just even little gas cards and that, and some gifts, that integrated care. So when we just re-looked at our studies here, we got our second visit up 90%, at 4 months we're 40%, 37 at 6 months, and 27% at 1 year. So that's pretty good compared to 9%. So I'm afraid to say quality worked. So, and just to finish up, a few alternatives that are out there, obviously methadone. So Vivitrol, do you have the poster boards out on the freeways for Vivitrol here yet in Kentucky? They're all over in Ohio. But so Vivitrol is a monthly shot. It's naltrexone, so it blocks all the receptors. To me, it's more of harm reduction, but I think we do have people on naltrexone. They tend to be people that have failed the outpatient treatment, got arrested, they were in jail for like 60 days, so they're completely clean. They've kind of gotten over that acute withdrawal. And then some of them do okay on the Vivitrol. They understand that they can't get high, so they don't waste their money. So it's not exactly treatment, but it is good harm reduction. Probuphine is out now. I don't think anyone's ever going to use it. Each of these is 2 milligrams of buprenorphine, which isn't much. Depo is not too far away, so probably a monthly shot. And just lastly, about overdose, every one of our patients we send home with an overdose kit. We originally made our own kits with a nasal atomizer, but this company just came out, and it's so simple. It's got 4 milligrams. Usually the dose was 1 in the home kits. Now it's 4, so you could hope to reverse a fentanyl overdose. All you got to do is jam that up their one nostril, push it in. So super easy. And when you write for this script, it's relatively reasonable. It's covered by Medicaid, and you get 2 of these with every time you get it. So probably half of our patients have witnessed a overdose. Something like 20% have actually overdosed already. Most of the time, the kits are not used on our patients, but they're used on a friend or something like that. So I kind of think of it like immunizations. So that's it. Any questions? Or
Thank you very much. In terms of prevention, could you speak to the generational aspects of addiction, the disease addiction, and how to prevent that from going into the next generation?
Yeah, I'm not sure I have the answer for that. I mean, we definitely know, as pediatricians, it's such an important thing to know about the family if there's a strong history, because we definitely know if both parents are alcoholic or have other issues, the kid has really got some high risk for that. So I think trying to help the family understand that it's important to try to present positive behavior. If you are going to overdrink, try to not be doing it in front of the kids. Pretty hard to do, I'd say. But I think as the parents, to try to keep giving them positive messages about trying to wait. Look what it's done for us. It's very difficult to treat. And I wish we knew more. And I virtually all things like smoking cessation, everything, the only things that work are basically what are called skill building techniques. So trying to give people a lot better self-esteem so that they don't feel like they have to smoke just because all their friends do. And treating any mental illness, obviously depression, anxiety drives a lot of, that's why a lot of kids start to smoke, because it calms them down and they just don't have other medications. So wish I had more, but
a wonderful presentation, and very scary as a grandfather of a 10-year-old. I read, I guess yesterday, a multi-page article in the New York Times about this new health bill that passed almost unanimously in the Senate and is certain to be signed by Obama. There was a supposedly major component of it to deal with narcotic addiction. And I wondered whether you are knowledgeable about what or if that will do anything towards adolescent substance abuse.
Yeah, I'm not sure it is going to. I have to say, the knee-jerk government response is we need a ton more providers. So, like, when I originally got my X number, you could see 30 people at a time. Once you've had it a year, so you can go up to 100. Now, in government wisdom, they've decided that people can see 275 people at one time, which I don't know how anyone could possibly do that. So they're going to get crappy care. And I have nothing against nurse practitioners and PAs, but by legalizing them, it just helps those unscrupulous doctors make a lot more money, because there's going to be one doctor, 5 NPs just cranking these out and making a ton of money. Now, if some of that money actually comes down and goes into treatment, because there really isn't enough good treatment out there. We can't find treatment programs for our patients, and we should be the smartest people around. So how a parent could ever find someone is hard to know. But hopefully some of the money will go into things. We can't even get somebody to fund an incentive program for us, and we showed that it worked incredibly well. I mean, kids just want a book or a $10 Walmart card, but people don't see that as an important thing. So hopefully if more money comes down, it'll trickle down to us. But obviously as a pediatrician, I think the prevention, if we could treat kids when they're drinking too much alcohol and smoking too much weed, I think we'd really decrease the number of kids that go on to be addicted to these drugs. And those programs, not much. I don't know. We were talking last night, not a whole lot here in the city. We don't have a lot in our city. We're basically it that'll see a minor.
I never thought that I would ever wish for the good old days when it came to heroin. But when I was a intern and resident at the University of Michigan, we rotated through a Detroit City hospital, and you had to learn about heroin. Heroin was tightly controlled by the mafiosi. Feel free to leave, folks,
if you need to. That doesn't irritate me
at all. And the mafia
controlled
every single dilution.
Yeah.
Our street heroin was 3 to 6% pure. You could count on it. You could take it to the bank. You knew what it was. Today, the major in charge of the narco squad here in Louisville, I asked him directly, what's the street heroin here? And he said someplace between 75 and 80% pure. And I said, and the overdoses were secondary to some amateur cutting it with liquid fentanyl, and he said exactly right. I mean, you've got problems now with addicts getting together, paying one guy to be sober and shooting up in the hospital parking lot and depending on the driver to take in anybody who wasn't breathing real good. So we've got a whole different ballgame running. When the mafia had it, it came from mostly southern France.
Yeah.
It came into Detroit on freighters,
nice.
in cars, and on the railroad.
Yeah.
And it was the same concentration.
Does anyone know where most heroin comes from these days? We're fighting a war over there. Afghanistan still produces most. And then Mexico is third, actually. So I might not have said it, too. I just want you to know that we have a lot of patients that succeed. So I would say we have 50 people that are out there. Half of them have come off the drug and are doing well. Half are taking that little bit. So it really does work. It's just a really hard disease to treat. And I think the sooner you can get it going, much more likely they'll come back. It's actually incredibly fun to do, and it's something you could easily do in your practice in a special half day or something. So thank you very much. One more.
A couple more questions.
Yeah.
I liked your slide about the quality improvements, and it included things like transportation. But could you speak a little bit about the motivational interviewing part, the training, may be a good resource for that. And then the second part of this is more for maybe Ken Schickler in the audience. If we have a 16 to 18-year-old child with heroin addiction, what are resources?
Yeah, I mean, the MI, obviously, I think everything is about changing behaviors. So, you can't come off as just another old fart telling them to not do it. So, you have to learn how to help them come to the decision that their life is really going to be better if they make this decision. So it's really a very soft approach of just trying to give information, trying to support good decisions, not beat them up when they make mistakes. And, unless you do it a lot, which unfortunately my social workers do most of it, so I get lazy, but we have little cheat sheets, and there is excellent. I know at the next American Society of Addiction Medicine, they're having a full-day training on motivational interviewing, which should be good. And you probably have people. We have people in Ohio that kind of come and will give you a day session to at least get you started, and it's fun, and it really is a different way to do things. And really, if you can't, we get kids in, they're smoking weed every day. I always the residents are like, yeah, he's smoking weed. I'm not beating up on you guys. But they're smoking weed every day, and it's just that they're so used to hearing that they accept it as okay, But it's like, that's not okay. I mean, your short-term memory is shot, not learning. I'm not going to give you ADD meds because the weed is making you not learn. So trying to intervene on those earlier times is really important. I'm sorry, I forgot what your second thing was. Oh, resources. I'm not sure what your resources are here now. You can always drive up to Columbus. We'll be glad to.
I think in the interest of time, we'll take further questions and comments
Sure.
at the podium.
Oh, he's got one thing. A lot of people are pretty scared about doing that, but I mean, they're treated the exact same way, so not that hard to do. Thank you very much, everyone.